Hello everyone. Today in this video we are going to talk about a very important disease which is related with the pulmonology and the lungs. This is known as the acute respiratory distress syndrome and we very famously known it as the ARDS. So let's talk about the ARDS. So first of all, we will define the acute respiratory distress syndrome, and as it is always said, try to concentrate on the name of the disease because there are certain literal meaning of the names. For example, when we say that this is acute, that means it is recently in its development. It's not a chronic one. So acute defines the duration, and respiratory distress means that patient had developed a difficulty in breathing, and the syndrome means that not only the lungs are involved but there are certain other organs which may be involved. So when we define the acute respiratory distress syndrome, there are certain characteristics or the parameters which we need to meet. These are that the patient should have recently developed the problem with the breathing, like they should have had a respiratory distress during the last week or some days. When you get the X-ray in these patients, there are bilateral, in majority of the cases these are the homogeneous infiltrates, but these can be patchy, diffuse, homogeneous, any sort of infiltrates on the both sides on the chest X-ray. But this is very important that first you need to rule out that there is no pulmonary edema because of the left ventricular failure. You need not to have a heart failure. So the pulmonary capillary wedge pressure or pulmonary capillary occlusion pressure should be less than 18 millimeter of the mercury, which effectively rules out the presence of the left ventricular failure. And lastly, majority of these patients, they end up on the ventilator, which is the mainstay of the treatment, and they are on the ventilator. We give them a positive end expiratory pressure which is more than 5 centimeter of the water, because it's a main thing in the treatment on the mechanical ventilator for these patients specifically. So when we count the partial pressure of arterial oxygen and divided by the fraction of inspired oxygen. Now we note the fraction of inspired oxygen from the ventilator and we get the partial pressure of arterial oxygen from the ABGs. So when we calculate the ratio PA2 over FiO2 ratio, in the presence of the PEEP, which is more than 5 centimeter of the water, if it is between 200 and 300 millimeter of the mercury, we categorize the case of the ARDS as the mild case. When the value or the ratio between the PA2 or FiO2 falls to less than 200 but stays above the 100, we call it the moderate case of the ARDS. And lastly, if somebody has got a PA2 or FiO2 ratio which is less than 100 millimeter of the mercury, then we call that this is a severe case of the ARDS. This is known as the Berlin definition of the ARDS. So when a patient meets these criteria, we call that the patient is having the acute respiratory distress syndrome or ARDS, which is very important while we are working in the ICU departments and the emergency department. Talking about the etiology or the causes of the acute respiratory distress syndrome, these can be broadly categorized into the two groups. One are those which are directly affecting the lungs. For example, if you see the case of the pneumonia and the gastric aspiration into the lungs, these are the gastric contents which are colonized, and when they are aspirated, they not only do the chemical injury but they start a process of infection into the lungs. So these two are the most common conditions which are directly affecting the lungs. Now the less common causes which directly affect the lungs, these are the lung contusions. It can be a reperfusion injury. For example, in case of the when you treat the pulmonary embolism and there is pulmonary embolectomy, that can cause the direct trauma to the lungs, and cases of the near drowning. So there are so many other causes which are less common but they do affect the lungs directly. Now there comes the causes which are not directly affecting the lungs but they somehow indirectly affect the lungs, or they indirectly injure the lungs. Most common cause will be the sepsis, which you come across in the intensive care unit or emergency medicine. Then there is a trauma cases where you have a shock in the patient. The blood pressure is less than 90 systolic millimeter of the mercury. Patient would have had a lot of blood transfusions, and sometimes a single transfusion can also cause the transfusion related acute lung injury. But the most common causes which are indirectly affecting are the sepsis and the trauma. Then sometimes the patients of the acute pancreatitis, they do affect the lungs indirectly, and there are drugs like the heroin which can affect the lungs. And last but not the least, burns cases do have indirect injury to the lungs. So these are some common causes, but the most common I have mentioned that these two, they directly injure the lung, and sepsis and trauma, they indirectly injure the lungs. Now, if we focus on the pathogenesis of the acute respiratory distress syndrome, we'll have to focus on the alveolus and the epithelium of the alveolus. We should focus on the interstitium, which lies between the alveolus and the pulmonary capillaries. Now, and this part, this is known as interstitium, and this part, which is the capillary endothelium. Now, whatever the cause is, be it the direct injury to the lungs or the indirect insult to the lungs, ultimately what happens that there starts a process of inflammation in the interstitium, in the capillary endothelium, and in the alveolar epithelium. These cells, they are damaged. There comes the neutrophils, there comes the other inflammatory cells, which then release a lot of inflammatory cytokines, and then within the interstitium and in the alveolus, there are a lot of fibroblasts, there are fibrin, fibrinogen, and ultimately it results in the formation of the exudate, and it becomes really difficult for patient to transmit the oxygen from outside the body and through the alveolus, through the interstitium into the pulmonary vasculature. So once this exudate is formed as a result of this inflammatory process which is going on in the interstitium, in the capillary endothelium, and in the alveolar epithelium, it becomes very difficult for the patient to breathe, because patient is short of breath and patient needs a lot of oxygen, patient feels air hunger. So this pathogenesis involve not only the inflammatory process, but this inflammatory process is later on followed by the development of the fibrosis, which sort of permanently remodels the lungs and especially the alveoli. So when we concentrate on the pathogenesis, we shouldn't forget the primary inflammation going on over here, and that is why we call that the ARDS is a part of the generalized inflammatory response to any insult, and it is a part of the MODS, or the multi-organ dysfunction syndrome, and the things which go to the other organs of the body are also going on in this part of the body, which we call the interstitium, alveoli, and the capillary endothelium. Now, talking about the clinical presentation of these patients of the ARDS diagnosis, their symptoms will be that they will be having a difficulty in breathing. They may be breathing more than the usual number of the times. There may be blueness of the tongue, and patient also complains of the other associated symptoms, like if the pneumonia turns out to be the basic cause of the ARDS, patient may give the history of the fever and cough and productive sputum of the yellow or the white color. So when the doctor checks the patient and elicits the signs, patient may have a high heart rate because of the low oxygen in the blood. Heart tries to compensate by increasing the rate. Patient may be taking a lot of breathing. Respiratory rate may be on the higher side, which we call the tachypnea. Normally, if the respiratory rate is 12 to 15, this patient may have 25, 30, going around that number of the times the patient may be breathing in and breathing out. There may be blueness of the lips and the tip of the nose and the tongue, which we call the central cyanosis, which we check when we are examining the patient. And when we auscultate the patient, we may find the fine crackles on the both sides. There may be on pulse oximetry, during the examination, the SpO2 or the oxygen saturation percentage may be less than 90%. So these are the signs and symptoms which we elicit and hear from the patient's mouth or the family's side when the patient present to the hospital. Talking about the diagnosis of the patients of the ARDS, in the how we can diagnose these patients. First of all, the clinical scenario or the clinical presentation is very important, which we know on the history and the physical examination. Then we get the chest X-ray of these patients where we see the bilateral diffuse and the patchy infiltrates. We do the pulse oximetry by applying the pulse oximeter to the finger, and we see that there is a hypoxemia or the saturation. SpO2 is less than 90% of the case, 90% in most majority of these cases. We get the arterial blood gases, and here we come across the type 1 respiratory failure where we see a partial pressure of arterial carbon or arterial oxygen which is less than 60 millimeter of the mercury. When we get the ECG, in majority of the cases we'll find the sinus tachycardia where we see a heart rate of more than 100, and we see that P is present and R2R is regular. And why the patient is having the sinus tachycardia? Because this is the compensatory one, because there is hypoxemia and heart is trying to just supply the oxygen required to the cells by increasing its rate. And finally, we can also get the high resolution CT chest where, because X-ray, if X-ray cannot show something, HRCT will surely show. So these are the bilateral pleural effusion. Then there can be bilateral densities, and we see the air bronchogram because there can be pneumonic patches, or ultimately these patients do develop bilateral densities which have got the bronchioles within them. So that just shows up as the air bronchogram. Talking about the management of the patients of the ARDS, the most important thing which is we shouldn't forget in these patients is that mechanical ventilation is very important in these patients. When we should put them on the ventilator? When as a doctor you are managing a patient of the ARDS and you think that the patient needs the mechanical ventilator, put the patient on the mechanical ventilator. This is the most important thing, but obviously you need to be an expert in that. If you are good enough while you are working in the intensive care unit and you think that patient is in need of the mechanical ventilation, pass the endotracheal tube and put the patient on the ventilator, taking very good care of these factors. You need to follow the lung protective ventilation, which means you should have a higher level of the PEEP, more than 5, roughly around 8 to 10 centimeter of water. Patient should have a less tidal volume to avoid the ventilator induced lung injury, barotrauma, and you should have a higher respiratory rate, so that you need to have a pH around like more than 7.25, and you must be accepting the PCO2 level of roughly like 40-50. Do not be very aggressive to get rid of the carbon dioxide, because for that you will have to increase the tidal volume and that can damage the lung. So we need to protect the lungs from the damaging effect of the tidal volume on the higher side. So and also we have to take care of the ventilator associated pneumonia by daily giving the mouth care and by keeping the head side of the bed more than 30 or the degree or the semi recumbent position. So mechanical ventilation cannot be overemphasized. This is such an important thing to do in these patients. The second very important thing which is should be understood is the fluid management. We need to keep these patients in the negative balance. We do not give a lot of fluids to these patients, but if these patients are in the positive balance, we need to use the diuretics. Even if the blood pressure goes down, we can use the inotropic sport in these patients. And if these patients have got a problem with their kidneys, because do not forget this is a syndrome, sometimes there is dysfunction of the kidney along with it, so you are to go for the hemodialysis, but ultimately you are to keep these patients in the negative balance. Do not forget this very important point. The third thing in the management is easy to listen, easy to understand, but difficult to perform. This is the prone positioning of the patient. You need to convert the patients from the supine to the prone position, and you are to keep the patient in that position for a long period of time, or you are to keep on switching the patient's position from supine to prone for many number of the times while the patient is on the mechanical ventilator, while the patient is in the critical state. Why it is difficult to perform? Because you need to have a large number of the people who can take better care of the endotracheal tube while you are changing the position of the patient. What is the benefit in changing the position of the patient from the supine to prone? In majority of these patients, the densities and the pleural effusion, they are in the dependent part. So when you change the position from the spine to the prone, then you can reduce the shunt and the dead space. Dead spaces are those where there is air but no blood, and shunt are those places in the lungs where when there is blood is present but no air is present. So you can reduce those, you can increase the compliance of the lungs in these patients because in the cases of the ARDS there is decreased compliance and increased respiratory distress as a result of that decreased compliance. So prone positioning very important. And then do not give steroids. There is no use of giving steroids. We are always very zealous in giving the steroids to every patient, but there is no beneficial role of the steroids in these patients. They can do more harm than the benefit nowadays, because in cases of the ARDS there is a vasoconstriction which increases the shunt. Because why? Because when there is vasoconstriction, there will be the blood will be going to that part of the lungs which do not need the blood. So we sometimes we use the vasodilator like the nitric oxide. We nebulize the patient with the nitric oxide, which again will decrease the shunt and help the patient. Then prostacyclin can be used in some of these patients, but it's again the vasodilator. It can be beneficial, it cannot be beneficial, but this can be used. Now surfactant is so oftenly used in the neonatal respiratory distress syndrome, and it's beneficial there, but in case of the adults there are no controlled studies which go in the favor of its continuous use. So when finally talking about the management in these patients, mechanical ventilation most important, but the doctors who are carrying out the mechanical ventilation in these patients should know all these factors. This is very important. Fluid management very important. And one thing which is also very important, if sepsis is the cause of the ARDS, you have to give broad spectrum antibiotic. If pneumonia is the cause of the ARDS, you are to start the patient with the broad spectrum antibiotics covering both gram-positive, gram-negative, MRSA and anaerobes. But once you have obtained the reports of the culture sensitivity of the tracheal secretions and the blood, then you will scale down or escalate the antibiotics targeting the culture and sensitivity report. So you need to manage the source of the infection. You need to do the prone positioning. So this is all about the management of these patients. The last point about the management is the prognosis in these patients. Now, in the old days, the mortality rate used to be more than 60%, but after the doctors adopted this lung protective strategy and negative balance of the fluids, then this mortality has decreased to less than 20%. So it makes such a huge difference between the prognosis. So always try to understand the basic concept of the management of the patient of the ARDS. So that's all about the ARDS, or the acute respiratory distress syndrome. If you are interested in working in the acute medicine, both in the emergency medicine and the intensive care medicine, then you should have a very good idea, a basic concept of the acute respiratory distress syndrome and plus and minuses of its management. And thank you very much for watching the video. If you like this video, please subscribe the channel and help in growing the channel further. Thank you again.